Hello everybody. Okay, today we are going to look at orthodontic indices. Okay, now what is the learning outcomes for this lecture? Now, students are expected to list and explain the properties of an ideal index, discuss in detail properties and applications of IOTN, describe components of ICON, describe in detail Summers occlusal index, describe the components and application of the PAR index. Now, what is the definition of an index? An index is a rating or categorizing system that assigns a numeric or alphanumeric label to a person's occlusion. Now, what is the purpose of an index? Now, an index can be used for epidemiological purposes, that is, to determine the prevalence and incidence of occlusal anomalies. It can be used for research purposes in the field of physical anthropology, and it can be used for economic healthcare planning to plan manpower needs and the financial outlay needed for provision of services. Now, it can be used for individual case assessment, whereby it can be used for diagnosis, it can be used to determine treatment need, treatment outcome, and the treatment difficulty or complexity. Now, the third purpose of indices is in the field of interdisciplinary communication. It can be used as a means for referral of patients. It can be used to obtain informed consent from the patient. It can be used to rank the severity of malocclusion. It can be used to determine the treatment difficulty and also used to monitor standards of treatment. Now, how do we classify indices? Now, you can classify indices either as qualitative indices or quantitative indices. Examples of qualitative indices are Engels, Tallard, McCall, Fish, Bjork and Curves and Solo, Profit and Ackerman, WHO FDI, and Kinan and Brook. Now, examples of quantitative indices will be Musser and Frankel, Vankirk and Pennell, Draker, Granger, Summers, and Salzman. Okay, we can also classify indices based on the purpose of their use. So the first purpose will be for diagnostic purpose, and under this comes the Engels classification and the British Standards of Institute Incisor classification. Now, the second purpose of using index is to assess the treatment need. Under this, we have the occlusal index of Summers, the index of treatment need, or by its acronym IOTN, the modified IOTN, the index of orthodontic functional treatment need, or IOFTN, and the dental aesthetic index, or DAI. Now, the third purpose of using index is assessment of treatment outcome or success, and under this group we have the peer assessment rating, or PAR. We have the Gosselin yardstick and a 5-year-old index, both of which are used for cleft patients. The fourth purpose is assessment of treatment complexity and difficulty, and under this we have your index of complexity, outcome, and need, or the ICON. And lastly, we have multi-purpose orthodontic indices, whereby they may serve more than one purpose as outlined above. An example of these is the index of orthodontic treatment complexity, IOTC, or index of complexity, outcome, and need, or ICON. Now, what is a requirement of an ideal index? Okay. Now, these are the 9 requirements that are laid out in the WHO report 1966. Now, in simpler terms, the requirements of an index are it should be reliable or reproducible, meaning it should be able to measure consistently at different times. Now, if the same examinations are repeated by the same examiner or different examiner, then the results should be the same. Number two, the index should be valid. In other words, it must accurately measure what it intends to measure. Results of applying the index must agree with the opinion of orthodontic specialists. Now, the third requirement, it should be sensitive and be able to detect small changes. Fourth, it must be acceptable to the public and the profession. Fifth, it must be objective, meaning require minimal judgment by the user. Sixth, it must be quick and simple to use, easy to remember and apply. 7, it should be quantifiable such that statistical analysis can be applied to the index, and it should be of low cost. Now let's have a look at the occlusal index of Summers, which was introduced in 1966. Now it has different scoring schemes and scoring forms in different stages of dental development. So there's separate scoring schemes for deciduous, mixed and dental permanent dentitions. Now under the occlusal index there are 9 weighted and defined measurements, namely molar relation, overjet, overbite, posterior crossbite, posterior open bite, total displacement, midline relation, upper median diastema and congenitally missing maxillary incisors. Now based on that 9 measurements, there are 7 malocclusion syndromes defined by this index. One is overjet and open bite. 2, distal molar relationship, overbite, overjet, posterior crossbite and midline diastema. Thirdly, mesial molar relation, overbite, overjet, posterior crossbite and midline diastema. Congenitally missing maxillary incisors. Tooth displacement, posterior open bite or mesial molar relation, mixed dentition analysis and tooth displacement. Now the next index is the Dental Aesthetic Index DAI, introduced by Cons, Jenny and cohort in 1986. Now this index is recognized by the WHO and is widely used in the United States. Now in this index, the aesthetic component or the patient's perception of the malocclusion and the clinical need are combined mathematically using regression analysis into a single score. Now earlier indices than this did not acknowledge the aesthetic or psychosocial factor of a malocclusion. Now the next index historically is the Peer Assessment Rating PAR, introduced in 1987. Now this index assesses the standard of orthodontic treatment achieved by the operator. Now it can determine whether the correct case selection was done for the purpose of prioritized treatment. It's a fast and simple method. It's quantitative and objective. Weighted scores are assigned to each occlusal trait, and this weighting is based on the severity of the occlusal trait and perceived difficulty of correcting it. Now, the PAR index is applied to pre and post treatment study casts. Difference between the pre and post treatment study cast indicate degree of improvement. The PAR assessment rating has 5 components. Firstly is the upper and lower anterior segments. Second, left and right buccal occlusion. Third, overjet. Fourth, overbite. And fifth, center line. Now, let's have a look at the individual components of the PAR assessment rating, peer assessment rating. Now, the anterior segments, the anterior alignment is scored from canine to canine using the mesial contact points from the canines. Now, the features recorded in the anterior segments are presence of crowding, spacing, and any impacted teeth. Now, if a space between two adjacent teeth is less than 4 millimeters, it's considered as an or scored as an impacted tooth. Now, the contact point displacement is considered as the shortest distance between contact points of adjacent teeth parallel to the occlusal plane, and this is the scoring scheme for the total displacement. Now, potential crowding in the mixed dentition is also assessed using average mesiodistal widths for unerupted teeth. Now, the average mesiodistal widths for unerupted teeth are except for the upper canines, which are 8 millimeters, the lower canines and all the premolars are considered to be 7 millimeters in width. Now, the buccal occlusion. The buccal occlusion is assessed in left and right sides in all 3 planes. It is assessed from the canine to the last molar. It's assessed with the upper and lower teeth in occlusion. Now, the anterior, posterior, vertical, and transverse scores are summed up for each buccal segment. So, this is the scoring scheme for the buccal occlusion scores. Now, the overjet. The overjet is assessed for positive overjet and anterior cross bites. It assesses all the incisor teeth, but only one worse overjet measurement is recorded. It's measured with the ruler parallel to the occlusal plane. Both the overjet and crossbite are recorded and the 2 scores are totaled up. So, this is the scoring scheme for the overjet and the crossbite, ranging from a score of 0 to maximum of 4. Now, the overbite is defined as the coverage of lower incisors, and it is one worse overlap or open bite on any of the incisors is recorded, and it is not summated. This is the score for the overbite and open bite, again ranging from 0 to maximum of 4. Now, the center line is the difference between the upper and lower midlines, and the center line is assessed in relation to lower dental midline and not in relation to facial midline. The scores range from 0 to a maximum of 2. Now, the peer assessment rating of PAR is validated by 74 dentists in accordance with British orthodontic opinion. It has different degrees of importance given to the 5 components by means of weighting. Each individual scores for each components are multiplied by the appropriate weighting and then total to get the final score. Now, this table shows the PAR weightings, and you can see, the overjet is given the biggest rating, which is multiple of 6, followed by the center line, which is a multiple of 4, overbite multiple of 2, whereas the anterior segments and the buccal occlusion are multiplied by 1. And these weightings are based on clinical experience. Now, how do you assess improvement with the PAR index? There are two methods of assessing. One is by use of nomogram or graphs, and the second method is to look at the percentage improvement. Now, the nomogram is a graphical illustration whereby the pre-treatment score is recorded on the x-axis and the post-treatment score on the y-axis. Now, pre and post-treatment score intersection on the graph shows the degree of improvement, and there are three areas in the graph coinciding to: 1, worse or no different in improvement; 2 is improved result; and lastly is greatly improved. Now, this is an example of the PAR nomogram. As you can see, the x-axis is the pre-treatment score and the y-axis is the post-treatment score. So if you look at this example here, if the pre-treatment score is 20 and the post-treatment score is around 18, then the patient malocclusion has not shown much improvement with treatment. And in this situation, the second example, if the pre-treatment score is 25, post-treatment is 15, then there has been improvement with treatment. And if the score, pre-treatment score is 43 and the post-treatment score is about 5, then the patient's malocclusion has greatly improved with treatment. The second way of assessing is to calculate the percentage improvement. Now, this is more sensitive than the nomogram, but we must take note that different reduction in actual PAR scores can produce an identical percentage change. If you look at this table, if we look at these two hypothetical situations, in the first case, the actual reduction is 32 score units, and the second example is reduction of 12 units, but yet both in terms of percentage reduction is 80% reduction. And if you use the nomogram, the first one will be fall in the category of greatly improved, while the second one will be just improved. Thus, it's important to record the actual reduction in the PAR score and not just the percentage reduction. Now, there is such a thing called a PAR ruler. It is designed to do the measurements easier, and there's information on the ruler which summarizes the index, which allows for quicker assessments. Okay, now please take note that some of these measurements, for example, like this overjet contact point and the overbite, now this is the score and not the actual measurement. So this ruler is placed against the study models and it directly reads the score and not the actual overjet measurement. Now, what are the shortcomings of the PAR index? Now, one, the PAR index does not assess teeth in relation to the face. The inclination and angulations of crowns are not assessed. Other outcome factors are not considered. Example, root resorption, enamel demineralization, bone loss, periodontal damage, residual buccal space, and relapse. And different countries use different weightings, in which case comparison between different studies are not possible. Now let's have a look at the index of treatment need by acronym known as IOTN, okay, which was introduced by Brook and Shaw in 1989. Now this index is widely used in the United Kingdom to rank malocclusions. It's used to determine eligibility for orthodontic treatment, prioritize care and referrals for those with the highest need. It's easy and quick to use since a single worst feature is chosen or recorded. It can be used chairside or on study cast. Now the index of treatment need has two components. One is the dental health component or DHC, which is based on the work of Linda Aronson done for the Swedish Public Dental Health Service in 1974. And under this component there are 5 categories or grades ranging from 1, which does not need treatment, to 5 very great need for treatment. Now the second component of the IOTN is the aesthetic component or AC component. Now this is the psychosocial component of the index. It's based on Evans and Shaw's work in 1987. Now it is based on lay people's judgment of 1000 photographs of 12-year-old occlusions, and from these 1000 photographs, 10 color photographs are chosen to represent a scale of 1 or most attractive to 10 or the least attractive. Now a score of more than or equal to 6 implies a need for treatment based on the psychosocial perception. Let's have a look at the dental health component of IOTN. There are 5 grades as I mentioned previously. Now these are based on occlusal features that could affect the function and health of the dentition. Now it is not cumulative, only a single worst feature is determined for the grade to be assigned. Okay, now this is the table shows the grading of the dental health component. Okay, now under category grade 5 you have all those features whereby there is a very considered to be a very great need for treatment, and you can see their subcategories. For example, A means increased overjet, H is for extensive hyperdentia, I for impeded eruption, M for reverse overjet, P defects in cleft lip and palate, and S for submerged deciduous teeth. Then you have grade 4, which is great need for treatment. After that you have grade 3, which is considered borderline need for treatment, grade 2 very little need for treatment, and grade 1 no treatment is indicated. Now the dental health component of IOTN can also be used on a dental cast, and in the dental cast protocol we always assume the worst scenario. For example, if the overjet is between 3.5 to 6 millimeter, then we assume that the lips are incompetent and give it a score of 3.8. Similarly, if the crossbite is present, we assume that the retruded contact position and the intercuspal position discrepancy is more than 2 millimeters, and we give it a score of 4C. Now a reverse overjet more than 3 millimeters is automatically given a score of 5M, assuming that there are masticatory or speech difficulty which is present. Now, how do you record a DHC score? One is we can record only the grade, which is simpler. For example, if our overjet is more than 9 millimeters, it's simply recorded as grade 5. Now, the second way of recording is to record both the grade and the initiating feature. For example, if the overjet is more than 9 millimeters, is recorded as grade 5.A. Now, this method gives more info on the prevalence for specific occlusal traits and is good for research purposes. Now, for the dental health component, there's a hierarchical scale. Now, the hierarchical scale is a guide to enable the examiner to assess the dentition in a systematic manner, ensuring that all relevant occlusal anomalies are identified. When more than one anomaly has the same DHC grade, the hierarchical scale determines which anomaly is recorded. Now, the hierarchical scale is known by its acronym MOGDO, and the MOGDO stands for missing teeth, overjets, cross bites, displacement of contact points, and overbites. Now, the DHC of the IOTN ruler also has a ruler which is designed containing brief information necessary to record the dental health component. As you can see in this diagram, there is a section here on the ruler which records positive overjet and reverse overjet, and the section here records contact point displacement and open bite, and this middle section provides a brief description of occlusal anomalies, and this majority are qualitative measurements. Closer look at the IOTN ruler. Okay, and this is an example of the rules used to measure overjet, and in this situation it is a 4.A, and this part of the ruler is used to measure contact point displacement, and in this situation it is a 3D. Now, let's have a look at the aesthetic component of the IOTN. This uses a 10-point visual scale consisting of 10 standardized color photographs, decreasing level of attractiveness from 1 to 10, meaning 1 is more considered the most attractive and 10 is considered the least attractive. Now, it is compared with the photographs are compared with the subject's teeth viewed from the front. Now, a score of 1 or 2 indicates no need for treatment. Score of 3 and 4 only a slight need for treatment. 5, 6 and 7 are considered borderline, and 8, 9 and 10 are considered definite need for treatment. So this is the 10 color photographs used in the visual scale for assessment of aesthetic component. So as you can see here, the number 1 is considered the most attractive, and number 10 is considered the least attractive, with the rest falling in between. Now, how do you use the IOTN? Now, often the IOTN is used only by using the DHC score to determine the treatment need. However, when the DHC score is borderline, then the AC score is used to determine whether the borderline case needs treatment. In the UK, the IOTN is used in the following manner. If the DHC grading is 1, then no treatment is provided under the National Health System, the reasoning being lack of health benefit due to almost perfect occlusion. Similarly, if the grading is DHC 2, again there is no orthodontic treatment provided under National Health Service, again due to the lack of health benefit as the occlusal irregularity is minor. Now, if DHC 3 and AC 1 to 5, then Normally, there is no orthodontic treatment under NHS unless there are exceptional circumstances like patient with class 2 Dept malocclusion with an traumatic overbite. Now DHC 3 grade 3 and an AC score of 6 to 10, or the DHC grade 4 to 5, these are eligible for orthodontic treatment under the National Health Service. The reasoning being more severe degree of irregularity to severe dental health problems are present. Now, what is the advantage of using a IOTN index? Now, it is able to rank occlusal disharmonies according to severity. It can establish treatment priorities, and it is uniform in assessment of treatment need. It can be used to counsel the patient. It can be used to plan and allocate resources, and it can be used for monitoring and promoting standards. No psychological component for dilemma of the patients with minor irregularity but with lack of self-esteem. Now, what is a modified IOTN? The modified IOTN basically is IOTN with a simplified scale. Now, it is simplified so that reliability is increased when it's used by non-orthodontists. Now, this is useful because for most basic surveys of occlusal anomalies, it's used for basic surveys of occlusal anomalies and not meant for detailed clinical evaluations. So, how is it the modified IOTN is different from the IOTN? Basically, the IOTN DHC component has 5 grades and 30 subcategories, and under the modified IOTN there's only 2 grades. Grade 0, which is no need for treatment, and grade 1, which has a definite need for treatment, and there are no subcategories. And similarly for the AC component, under IOTN we have 10 grades, whereas in the modified IOTN only grades 8, 9 and 10 are recorded. Now, Burden et al. In 2001 has found that the modified IOTN has better agreement among the examiners, and because it's simpler, the training period for examiners are shorter, because the examiners only need to remember cutoff points defining definite treatment needs. In other words, if you look at overjet, the examiner only need to know the amount of overjet that will put the patient in category 4 and need not know the amount of overjet that will put the patient in category 5. Now, the next index we're going to talk about is the index of complexity, outcome and need, going by the acronym of ICON. Now, this was developed by Daniels and Rickman. The index measures the following: the dental aesthetics as given by the aesthetic component IOTN, the presence of crossbite, anterior and vertical relationships as determined by the PAR index, upper arch crowding and spacing on a 5-point scale, buccal segment anterior posterior relationship as determined by the PAR index. Now, the above measurements are added to produce a score, and this score range determines the treatment need, complexity and degree of treatment improvement. Now, there are other indices that are also have been introduced. For example, Memorandum of Orthodontic Screen and Indication for Orthodontic Treatment by the Danish National Board, Ideal Tooth Relationship Index by Hager, introduced 1992, Need for Orthodontic Treatment Index or NOTI, introduced by Espelin at 1992, Risk of Malocclusion Assessment ROMA, introduced by Russo et al. In 1998, and Baby ROMA introduced by Gripaudo et al. In 2014. Now, a word about aesthetic indices. Aesthetic indices are mostly subjective in nature. Now, it is not suitable for assessing treatment in a research setting or in a situation where resources are limited and there is a need for resource allocation. Now, what are the indices used in Ministry of Health Malaysia? The Ministry of Health Malaysia uses the Index of Orthodontic Treatment Need for prioritizing treatment need or referral need among Malaysian patients. This is necessary because on the average there is a 5-year waiting list at most Ministry of Health orthodontic units. Number 2 is the peer assessment rating, which are used to monitor KPI standards and to assure that treatment is not concentrated for mild cases. There has also been attempts to introduce the Dental Aesthetic Index, though this is still in its trial stage. Now, in conclusion, the development of occlusal indices is an attempt to quantify malocclusion, and these indices can be used for the purpose of research, audits, and practice management. Now, the most important advantage of using occlusal index is to maximize consistency between and within examiners. Now, there is no universally accepted index for measuring malocclusion, but having said that, the occlusal index is recognized as having the least amount of bias. It has the best correlation with clinical standards and is considered the most valid of all the indices, but it is not ideal for assessing treatment outcome. Now, these are the references for this lecture, and thank you for listening.